Our next speaker is Dr. Raghav Malik. He's a cataract and refractive surgeon with Center for Sight, and he's dealing with refractive surgeries on large volume. So he's going to cover IOP, rising keratorefractive surgery, and the phakic IOL for us. Thank you.
Thank you, ma'am. So today I'll be speaking about, so there are two types of refractive surgeries in general. One is a cornea based, that is a laser vision correction, and the other is a phakic IOL. So both sets of surgeries do have their own complications, their rises in IOP, and there are certain factors which we have to consider keeping in mind whenever the pressure rises in a post LVC and a post ICL. So the morbidity of glaucoma, as spoken by my co-instructors till now, among myopes is much higher than the normal general population. So we always have to keep that in mind. So if you look at laser vision correction and raised IOP, so I would not say most, but yes, many of our myopic patients are at greater risk of steroid response. There are many factors which are not known till now, but yes, if we do have a myopic patient who is given a steroid, the chances that he or she will develop a steroid response are much higher than normal population. So we have to keep that in mind, and couple that with a thinner pachymetry after a corneal surgery, we will have a higher pressure because of steroid response and an under-read IOP reading. So we have to consider both of these options. Now, steroid-induced glaucoma, steroids are commonly given after LASIK or any corneal procedures just to decrease the corneal haze and avoid a myopic regression. Manifestation of steroid-induced glaucoma is similar to POAG, and myopia is always vulnerable to elevated IOP. PISC has been described by Dr. Tulika, so I won't go in detail. But yes, topical steroids are not only ineffective but also may aggravate the corneal haze, so we have to consider before giving steroids in cases of PISC. Goldman apnea tonometry is a gold standard for IOP measurement, but yes, the jury is out whether you want to use the Goldman immediately after a LASIK, because we have a flap that is still in the weak stage. So we have to consider whether we should give in a Goldman or not, or should we consider a DCT or just an NCT. So thinner than 520 micron cornea leads to an underestimated IOP readings, and lesser pressure is required to flatten the cornea. So we will have under-read readings. This is of course the chart that we use for IOP correction in a normal cornea if that has not undergone refractive surgery. How much we add the pressure or decrease the pressure given this is basis the average Indian cornea. So if we have a 540 micron cornea and a -8 diopter refraction, and we make a 110 micron flap, approximately 100 micron ablation, that is about 220 micron reduced. So the post-op cornea is 440, and the IOP that we get after the surgery is 18. Is everything okay? So we see that there is almost a +7 correction, that this 18 could actually be 25. Of course, these readings are very dynamic. 18 is not always 25, but yes, even if it is 23 or 24, that person could be having continuous loss in RNFL. So we have to consider this. So corneal flap interface fluid after a LASIK also caused a lower IOP leading. So immediately in the post-op period, there is some haze or there is some fluid inside the stromal pocket in a relax or inside the flap of a LASIK, which can give us an elevated IOP. So this has also been reported a potential lifelong complication after LASIK, that is interstitial fluid syndrome, potential space between the flap and of course the pocket and smile. Clinicians might increase steroids to decrease this, but this will further increase the pressure. So it's a continuous cascade that begins, and we may end up causing much more harm to the patient. So treatment of raised IOP after an LVC, there is no particular protocol. There's combination of anti-glaucoma medications we use. We as a practice surgeon should not treat the patient ourselves. We should always include a glaucoma surgeon or glaucoma physician in our treatment of a post-op raised IOP in an LVC patient. But generally we switch to low potency steroids, or we decrease the frequency, and also complete stoppage of steroids, but the patient has to be kept under observation very frequently. Now post ICL, yes, there is a rate of occurrence of raised IOP, and it has been reported from as low as 0.8% to as high as 26%. There are many surgeons who do their ICLs under hydration without viscoelastics. They say yes that the pressure rise is much less, because a bolus of viscoelastic under the ICL is something that can cause some increased volt in the initial phase and can give us a rise in IOP. So I'll just quickly show a video of an ICL being implanted under the ASOCT. Yeah. So I'm not showing the loading and the surgery. What I just want to highlight is that once the ICL is loaded inside the injection inside the eye, you can see immediately, you will see a very good volt. So you see in this towards your right, let me just focus on the OCT. Yes, so just look at this image. So this is our volt of the lens, and this is the volt that we have between the ICL and the cornea. So this volt, immediately you can see if it is very high, we can have an angle, we can preclude the patient to an angle closure. So prevention is always better than cure. Systemic and ocular history is very important. Refractive status, slit lamp biomicroscopy, endothelial cell counts, biometry, keratometry, pachymetry is very, very important. Intraocular pressures and gonioscopy before a phakic IOL, just to see whether the angles are open or not and is there any pigment dispersion or not. So factors that predispose an eye to high IOPs, position of the ICL. Like I said, we should do a very good ASOCT to see the volt. The volt should be measured. This I learned from Dr. Tulika, that even on the first day, you should measure the volt. If your vaulting is high or it is increasing progressively, we should take into consideration that and manage the patient accordingly. Pupillary block, yes, the anterior lens vaulting designed to prevent crystalline lens contact predisposes the eye to pupillary block glaucoma, and then a prophylactic PI is recommended. The new models of ICL that we have, that is the version 4C, that has a centra flow which is 3.6 millimeters, and that central aperture acts as an outflow duct for the retained viscoelastic. So the chances of increased IOP have now decreased since the new version of the ICL. This is an inverted phakic IOL. Of course, if this patient comes to you, you will have shallow AC because of the inverted ICL, and this will cause an angle closure and increase the pressure. This patient warrants a removal of the ICL, and then yes, we flip it over. This is quickly a case detail of a 34-year-old male who came with both eye contact lenses, wanted refractive surgery. He had a very high power, went in for an ICL. Pentacam was fine, gonioscopy was fine pre-operatively. Everything was fine. AC depth was good. He also underwent a YAG PI. Because this was in the times of the V4B model, there was no center flow. You can see right eye, the patient underwent IPCL. And after the surgery, you can see the pressure is now increasing. This was the pre-op, and now 42, 45, and the patient came with pain. So when we did see, yes, that the vaulting in the second day was 375, and 13th day the vaulting is increasing, and because of this the pressure is increasing. So this patient had to ultimately undergo an ICL explantation, and then he was given drops before anti-glaucoma drugs prior to ICL removal, but IOP was not controlled, therefore an ICL removal was warranted. Okay, so yes, this you can see this study shows very clearly that with the centra flow, the chance of IOP pressure increase are much lesser than with the V4B model, which did not have a centra flow. So retained viscoelastic or intraoperative AC overfill can be a cause of increased pressure, so that we should consider. Also the type of viscoelastic we are using. If we are using a cohesive that comes out as a bolus, which might not increase the IOP as much as a dispersive viscoelastic. Pigment dispersion because of the ICL touching the iris can cause more iris dispersion and can lead to increased pressures. High volt because of increased AC crowding or incorrect measurement of the ICL size, or a long-standing PAS can cause increased pressures. So this can be confirmed on the ASOCT. Pre-existing juvenile open angle glaucoma, which of course my colleagues have discussed, should be ruled out. Malignant glaucoma, yes, this is a very dreaded condition. This will require ICL explantation and most probably also a vitrectomy. Steroid response has also been discussed, yes, to differentiate from visco overfill, whether the increase in IOP is because of the increased viscoelastic in the AC or the patient is responding to your steroids. The AGM might be required. So to conclude, yes, there can be increase in IOP both in LVC and in post ICL conditions. We have to differentiate the two. What is the cause and what should be the treatment? Glaucoma medications is the management, but yes, we do require a glaucoma surgeon on board. And other causes of IOP could still be a problem. With the newer model of the central flow ICL, the chances of increased IOP are much less. Thank you.
Thank you, Dr. Raghav.
Thank you, ma'am.
So it was a wonderful presentation. I have a question for you. So do you do the glaucoma evaluation for all your keratorefractive as well as your phakic IOL patients?
Definitely, ma'am. Me as a refractive surgeon, all patients, even if I have the slightest suspicion, even if I have a 0.5 disc, which is pretty common in myopes, even if I have a 0.5 disc or a mild asymmetry of 0.5, 0.3 or 0.6, 0.4, I definitely send my patients at least a visual field, a baseline visual fields, and a baseline RNFL has to be done, so that even if the patient, there is a good probability I will not see that patient when he does develop glaucoma. He might be coming up when he's 40 to some other surgeon. So these baseline tests would probably help that surgeon at that time. So doing those tests right now for my conscience is very important, because that patient, like you said, will not develop glaucoma right now, but 15 years or 20 years down the line, depending on when he gets the surgery done.
So shouldn't it be a norm to do the glaucoma evaluation for all the patients who are undergoing these surgeries, not only the baseline or the borderline patients, right?
Yes, again, ma'am, the thing is that any other surgery would not be a surgery that is warranted. A refractive surgery is something that the patient comes with.
Yeah.
So this is an added set of complications we might give to the patient, because the patient does not know that these are an added set of complications that could happen and will stay with him for his entire life.
Thank you very much, doctor.
No, sir. If we see the lens as such will be the same powers, and the biometry will not be changing. We can use the same lens in the same setting. Yes. No, sir. The ICL is very, very soft. It can just come out from the same incision. Yes. Unless we have an under or oversized ICL. So we actually should. This happened. So to center for sight, yes, but I don't know about smaller practices. But yes, they do replace it.
So by actually, if we are using star ICL, they charge for the another lens usually. But if the calculation is done by them and they suggested the lens, usually the second lens is free of cost. They follow all over. I don't.
This happens about a couple of months back. I was injecting an ICL and the cartridge broke off. So there was no cartridge in our Dwarka center or the Sabdurjung center. So we had to call up the Star guys, and within 2 hours they had from the Lajpat Nagar center, they sent the cartridge to us, and the same ICL was again implanted. So we'll do an ASOCT. On the ASOCT, we'll see that there is very, very low vault. We'll see the concavity, because the lens has a concavity with the convexity outwards. But if we have the convexity towards the lens, we can see it's a flipped ICL. So about 1 to 1.5 times the corneal thickness, which is about 250 to 750 is considered normal. 250 is on the lower side, but yes, I think about 400 to 750 is the perfect size. Above 850 you should be cautious, and below 300 we should be cautious. And also the change in the vault from the first day to the first month. Thank you, sir.
Thank you, Dr. Raghav.